I mean, Waldenström's is a rare disease, but truth be told, the large majority of these patients are still being treated in the community. And I think it's important for the physicians in the community to diagnose Waldenström's properly. And I think we can do that through, understanding the presence of the monoclonal IgM protein, the need of a bone marrow biopsy to formally make a pathological diagnosis of a lymphoplasmacytic lymphoma, and also send either a PCR or an NGS panel to identify the mutation in MYD88. With those three factors, I think we have a high likelihood of dealing with a patient with Waldenström's. The next step is to decide if the patient needs to be treated or not. A majority of patients with Waldenström's, or a portion of patients with Waldenström's in my clinic, are actually asymptomatic at the time of diagnosis. Those patients should not be treated. I mean, those patients have a normal life expectancy. We are not curing Waldenström's, and all our treatments have potential toxicity. So those patients should be observed over time, and there are ways to estimate what the risk is of beginning treatment in the future, and that can be a tool that can be found at the awmrisk.com website, and then you can actually make a good estimate. Once the patient needs to be treated, there are a bunch of different options, and I think we have the chemoimmunotherapy and we have the BTK inhibitors, and I think the sequencing of these agents is not very clear in terms of which sequence is better, but I think those are the two frontline treatments that these patients can actually get. In the relapse setting, then obviously that becomes a little more challenging because there are multiple options, but I do believe that every patient with Waldenström's, regardless of which line of therapy they will be, are good candidates for clinical trials. So I think our colleagues in the community should think about a clinical trial as an option to treat patients with Waldenström's as well in the future.